Welcome back to the deep dive. Today we're plunging into something really fundamental, the silent conductor of life's rhythm. The heart's incredible electrical system. It's, just a marvel of precision, keeping us ticking day in and day out, making sure every beat is perfectly timed.
It really is.
But what happens when that rhythm falters, when the silent conductor misses a beat or, races wildly out of control, throwing the whole orchestra into disarray?
That's precisely the journey we're embarking on today. This deep dive is all about cardiac arrhythmias, those disturbances of the heart's normal rate and rhythm.
Okay.
And for you, as third-year medical student, this isn't just like an interesting topic. It's absolutely critical. These concepts are foundational for your upcoming exams and, even more importantly, for your future clinical practice.
Right.
You'll be seeing these conditions, diagnosing them, and managing them probably every single day.
So think of this as your comprehensive walkthrough, building directly from that detailed lecture series you've been given. We're going to take you on a structured journey, moving from the foundational knowledge of cardiac electrophysiology right through to the clinical application of understanding arrhythmias.
Yeah, it can seem complex, but we're going to try and untangle it.
Okay.
Our mission today is really to distill the most important insights from that material, clarify those intricate concepts that sometimes feel like a tangled mess,
Definitely.
and provide you with a robust framework for understanding and diagnosing arrhythmias. We'll paint a clear picture, piece by piece, so you can not only identify these conditions on an ECG, but also really grasp their underlying mechanisms and, critically, their clinical significance.
Right.
Consider this your shortcut to being truly well-informed and prepared for, well, pretty much anything that comes your way in the clinic regarding rhythm.
All right, let's unpack this by first establishing our baseline, a quick but crucial review of how a normal heart's electrical system should work. It's truly like a symphony, isn't it, with the sinoatrial or SA node leading the orchestra?
That's exactly where it all begins. The SA node, nestled there in the right atrium, is the heart's primary pacemaker. It possesses this remarkable specialized tissue that allows it to generate its own electrical impulses spontaneously without needing any external stimulation.
And why is it the primary one?
Well, the fundamental reason it's the primary pacemaker is simple. It inherently generates impulses at the fastest rate. It basically sets the pace for the entire heart and overrides any other potential pacemakers trying to chime in.
So it's the conductor setting the tempo. Okay. Once that impulse fires from the SA node, how does it then spread out so quickly and efficiently through the atria before hitting that crucial next checkpoint?
Right, so from the SA node, the electrical signal travels incredibly rapidly towards the atrioventricular, or AV node. This swift journey across the atria is facilitated by specialized conduction pathways and very large fibers, kind of like Purkinje fibers.
Okay.
The sheer size of these fibers, combined with an abundance of specific sodium channels, allows for this incredibly quick depolarization and swift conduction, ensuring the atrial muscle cells get the signal efficiently.
And then it hits the AV node, which we often hear called the critical delay point.
Oh.
What's the real purpose of that delay? Is it just like a speed bump, or is it doing something vital?
That's a fantastic question, and it's where the elegance of cardiac physiology really shines. The AV node is unique. Unlike the rapid sodium channels that drive conduction in most other cardiac tissues, the AV node relies predominantly on slow calcium channels for its conduction.
Oh, okay. Slow calcium channels.
Exactly. This inherent reliance on slower channels creates a built-in crucial delay in the impulse's journey from the atria to the ventricles.
And the importance of that delay isn't just a physiological quirk, is it? It has profound mechanical implications for how the heart actually pumps blood.
Absolutely.
Yeah.
This delay is physiologically indispensable. Think of it like this. It ensures that the mechanical contraction of the atria, that final squeeze that pushes blood into the ventricles and really optimizes ventricular filling, is fully completed before the electrical signal reaches the ventricles and triggers their subsequent contraction.
Right, timing is everything.
Precisely. If there were no delay, the atria and ventricles might contract almost simultaneously, which would lead to incredibly inefficient filling and a significant reduction in cardiac output. This perfectly timed sequence is fundamental for optimal ventricular filling and therefore the most efficient cardiac output. It's about maximizing every single beat, ensuring the ventricles are primed before they eject.
Makes perfect sense. So once the signal gets past that crucial delay in the AV node, it needs to rapidly spread to ensure the ventricles contract in a synchronized, efficient way. How does that happen?
Right. So after the AV node, the signal proceeds into the bundle of His. Now, this tissue is designed for incredibly fast conduction, using those same rapid sodium channels we talked about earlier.
Yeah.
This rapid conduction is essential for quickly distributing the impulse to the main ventricular conduction system.
And from the bundle of His, it then spreads out. How does it make sure both ventricles contract together?
Exactly. The bundle of His promptly branches into the right bundle branch and the left bundle branch. These are specialized pathways engineered to ensure synchronized depolarization of both ventricles.
Okay.
The right bundle branch conducts electrical events down the septum to the free wall of the right ventricle. The left bundle branch is even more intricate. It's composed of two fascicles, an anterior fascicle, which conducts to the anterior and lateral walls, and a posterior fascicle, guiding the impulse to the posterior wall.
Wow, okay.
These bundle branches, again, consist of large radius fibers that rely on those rapid sodium channels for swift conduction. This incredibly fast, coordinated spread of the electrical signal is paramount for ensuring synchronized ventricular contraction, which is the absolute foundation of effective blood ejection and maintaining cardiac output.
It's incredible how many layers of backup the heart has built in. We know the SA node is the main pacemaker, setting the primary rhythm, but what if it, falters? Are there other parts that can pick up the slack?
That's a truly fascinating aspect of cardiac physiology, isn't it? While the SA node sets the fastest rhythm and thus typically dictates the heart rate, many other cardiac tissues possess their own intrinsic capacity to generate pacemaker potentials. They just do so at progressively slower rates.
Oh, okay.
This inherent ability is a vital fail-safe mechanism, ensuring the heart doesn't simply stop beating if the primary pacemaker fails for some reason.
So what are those critical backup rates? For us as medical students, knowing these specific intrinsic rates is really important for identifying what happens when things go wrong,
Right.
for recognizing those escape rhythms.
Absolutely. These numbers are diagnostic gold. You need to know these. The SA node typically generates impulses at 60 to 70 beats per minute, often cited as 72 BPM, though its physiological range is wide.
Okay, 60 to 70.
If the SA node fails, the AV node is the next in line. It can take over, generating impulses at roughly 40 to 50 beats per minute.
40 to 50 for the AV node. Got it.
Even further down, the bundle of His has pacemaker capacity, but at an even slower rate than the AV node. And lastly, the ventricular bundle branches themselves can generate impulses, but at a very low rate, typically 20 to 40 beats per minute.
Wow, 20 to 40. That's slow.
Very slow. Understanding these intrinsic rates is crucial for you to identify escape rhythms in arrhythmias. These are the rhythms where a slower, lower pacemaker has taken over because the primary one has failed or is blocked. It tells you where the problem likely lies.
Okay, so we've got this amazing, complex electrical system, and the ECG, the electrocardiogram, is our window into it, right? Our way of reading its electrical story. To really understand and diagnose arrhythmias, we need to be masters of what each wave on that ECG corresponds to physiologically.
That's a fundamental truth. Your ECG interpretation skills will directly translate into patient care. Let's break it down. The P wave represents atrial depolarization.
Okay.
Think of your ECG as a camera only snapping a picture when there's movement or a change in electrical charge. That P wave only shows up when the atria are actively depolarizing, creating an electrical wave for the machine to detect.
And once they're all depolarized.
Once the entire atrium is depolarized, it's electrically flat again, relatively speaking, and the line goes straight.
And then there's the PR interval, that flat line between the P wave and the big QRS complex. This is often a source of confusion, I think. What exactly does it represent, and why is it so important?
The PR interval, that period between the onset of the P wave and the onset of the QRS complex, is a crucial indicator. It primarily represents the delay in conduction through the AV node, as we just discussed. But technically, it also includes the very brief time it takes for the impulse to travel through the atria and the bundle of His.
Okay.
Its clinical relevance cannot be overstated. Variations, or especially prolongations in this interval, are your primary clue for identifying AV nodal pathology, such as various forms of heart block. It's telling you if the signal is getting through that AV node correctly and on time.
Got it. Next, we have the dominant QRS complex, which is the big one that jumps out at you. What's happening electrically there?
The QRS complex represents ventricular depolarization. Now, here's a key insight and a common point of confusion. The large electrical deflections that produce this complex only occur during the early phase of ventricular depolarization. Specifically, this is while conduction is occurring rapidly down the bundle branches, spreading from the septum out to the outer walls of the ventricles.
So it's mainly the bundle branch conduction we're seeing.
In large part, yes. The QRS complex largely represents conduction through the bundle branches and that initial ventricular activation. Now, here's the confusing bit for many students. During the ST segment, the flat line after the QRS, the ventricles are actually mostly depolarized. Even though they are electrically active, there's no significant potential difference across the ventricular tissue because they are largely uniformly depolarized at that moment. Hence, no significant recording occurs on the ECG during the ST segment. The line goes flat. It's only when there's a change or difference in electrical potential that the ECG records.
Okay, that clarifies the ST segment mystery. And finally, the T wave. What electrical event is that signifying?
The T wave represents the early phase of ventricular repolarization. The heart muscle cells resetting their electrical charge to prepare for the next beat.
Ah, repolarization.
Similar to the P wave. It's this early phase of repolarization that allows for a potential difference to occur across the ventricular muscle and for the T wave to be generated. If the ventricles were completely repolarized and electrically uniform, there would again be no potential difference, and thus no T wave. So this T wave is our window into the initial stages of the ventricle resetting itself electrically. It's a critical indicator of myocardial health.
Okay, so that's the normal symphony, the precisely timed orchestration. Now let's turn to when it goes off key, when that rhythm falters. For us as medical students, we really need a systematic approach to classifying arrhythmias. What's the foundational definition we're working with here?
Right, the foundational definition of an arrhythmia is pretty straightforward. It's a disturbance of the heart's normal cardiac rate and/or its rhythm.
Rate and/or rhythm, okay.
It's that simple, yet incredibly profound in its implications. Now, before you even look at an ECG, a critical practical tip for any clinical scenario: always feel the patient's pulse. Is the rate too low or too high? Is the rhythm regular or irregular? This initial, quick assessment provides invaluable clues and guides your subsequent, more detailed ECG interpretation. It's your first diagnostic step, really.
That's a great practical starting point. So if we break it down further, we're broadly looking at issues with the heart's rate and issues with its rhythm, correct?
Precisely. In terms of rate disturbances, we classify them simply as either bradyarrhythmias, which are very low heart rates, or tachyarrhythmias, which are very high heart rates. Straightforward enough.
Okay. Brady and tachy.
Now, rhythm disturbances are where things get a bit more nuanced. They can occur in the context of both brady and tachyarrhythmias, but they also include a unique, very common category: extrasystolic beats.
Extrasystolic beats. Okay.
You'll hear these referred to interchangeably as ectopic beats or premature beats. Just to clarify the terminology, extrasystolic simply means they occur outside the normal systolic period. Ectopic refers to their origin not being from the normal spontaneous pacemaker areas, like the SA node, and premature simply means they occur before they should normally. Gotcha. Extrasystolic, ectopic, premature, same thing. All three terms describe the same phenomenon of an unexpected early beat, yes.
That's very helpful for demystifying the terminology. So diving into bradyarrhythmias, when the heart slows down, how do we anatomically classify where the underlying problem is?
For bradyarrhythmias, we primarily look at two main areas of anatomical pathology. First, we consider pathology in the sinoatrial, SA node itself. This includes conditions like sick sinus syndrome or sinus arrest. These are fundamentally disorders of impulse formation. The heart just isn't generating enough impulses to maintain a normal rate.
So, problem at the source.
Exactly. Second, we examine conduction defects, which are abnormalities in the electrical conduction pathway from the SA node down to the ventricles. This includes heart block, specifically AV nodal block, where the pathology is within the AV node itself.
Okay, the AV node bridge is faulty.
Right. And it also includes bundle branch blocks, where conduction through the normal bundle branches is impaired. Now, a crucial nuance for you as students: while bundle branch blocks are often grouped under conduction abnormalities due to their shared pathophysiology, they generally do not cause a reduced heart rate.
Oh, right, you mentioned that.
They affect how the ventricles depolarize, changing the QRS shape, not necessarily how often they depolarize. So they impact the ECG morphology more than the actual rate.
Got it. Okay, so for tachyarrhythmias, where the heart is racing, we frequently hear terms like flutter and fibrillation. What's the key clinical and ECG distinction there? Because they sound similar, but I know they're very different.
That's a truly crucial distinction that will guide your acute management. Flutter refers to a rapid but regular heart rate. Think of it like this, to give you a mental image. If you were to close your hand and open it very fast, repeatedly, with perfect rhythm that's flutter, it's rapid, but it's regular and organized electrical activity.
Okay, fast but regular, like a hummingbird's wings, maybe?
Sort of, yeah.
Oh.
Fibrillation, on the other hand, is an irregular but fast heart rate. To mimic this, imagine a gross intention tremor with your hand. It's fast, but chaotic and utterly irregular.
Oh, okay, fast and chaotic. That's a great visual.
This mental image can really help you differentiate them clinically and when looking at the ECG. Flutter is organized chaos. Fibrillation is just chaos.
And these tachyarrhythmias, just like extrasystolic beats, can originate from different parts of the heart, either the atria or the ventricles, correct?
Precisely. Tachyarrhythmias and extrasystolic beats can originate from either the atria or the ventricles. This anatomical origin dictates their specific name. Hence, we have terms like atrial fibrillation or ventricular fibrillation and atrial premature contractions, APCs, versus ventricular premature contractions, VPCs.
Okay.
And just to reinforce, remember that supraventricular is a broad term used for anything originating above the ventricles, including the atria or the AV node. So an atrial premature beat is often also referred to as a supraventricular premature beat, or SVT, for supraventricular tachycardia if it's sustained.
Right, supraventricular meaning above the ventricles. Got it. So if we're looking at an ECG, how do these flutter and fibrillation patterns visually distinguish themselves? What are the key ECG hallmarks?
On an ECG, the distinction becomes quite clear, usually immediately obvious once you know what to look for. For atrial flutter, you'll see multiple regular, very fast, small waves. These are your P waves, but they often look different, like a classic sawtooth pattern, particularly in leads like 2-3 AVF. The key is their regularity and rapid atrial rate.
Sawtooth waves.
Okay, these are usually accompanied by regular but typically slower, larger QRS waves because, importantly, not all those atrial impulses get through the AV node. There's often some degree of block.
Okay. And ventricular flutter.
In ventricular flutter, you'll see regular, very fast, large waves that essentially are the QRS complexes, but they look very abnormal, wide, and sinusoidal. It looks like a continuous undulating wave, making it hard to distinguish individual P, QRS, or T waves. It's just this rapid, regular, wide, complex rhythm.
Okay, big regular waves. Now, fibrillation. Atrial first.
Now, for atrial fibrillation, you'll observe many different irregular small waves, those chaotic fibrillatory P waves, which are often unidentifiable as distinct P waves. It just looks like a wiggly baseline. And critically, you'll see irregular large waves, the QRS complexes, because the chaotic atrial impulses hit the AV node irregularly, and not everyone gets through. The ventricular response is irregularly irregular.
Irregularly irregular. That's the classic description for the pulse too, right?
Exactly. And finally, ventricular fibrillation is characterized by very large, extremely irregular waves, where any organized electrical activity, and thus any differentiation between atrial and ventricular electrical events, is completely lost. It's just chaotic, uncoordinated electrical activity, a terrifying scribble on the screen, life-threatening.
Okay, that's a clear breakdown. So to summarize the anatomical origins of arrhythmias, we're essentially looking at two broad categories of electrical issues within the heart.
Yes, think of it this way. First, there are conditions of decreased electrical activity, which predominantly cause bradyarrhythmias. These represent abnormalities of the heart's natural pacemaker tissue, or its conducting tissue.
Right.
This includes issues in the sinoatrial node, like sick sinus syndrome or sinus arrest, the AV node, leading to heart block or atrioventricular nodal block, or the bundle branch block. The core concept here is a reduced ability to either generate a pacemaker potential or to conduct impulses efficiently. It's the conductor being too slow or the pathways being blocked.
Makes sense. And the second category then would involve anything that creates extra unwanted electrical activity.
Exactly. The second category involves additional or ectopic electrical events, which give rise to tachyarrhythmias or extrasystoles. These stem from abnormalities of non-pacemaker or non-conducting tissue that somehow become irritable and start firing off impulses when they shouldn't.
Okay.
This can be of atrial origin, like atrial extrasystoles, ectopics, or premature contractions, or the rapid rhythms of atrial flutter and fibrillation. Alternatively, they can be of ventricular origin, such as ventricular premature beats, ectopics, or extrasystoles, or the life-threatening rhythms of ventricular flutter and fibrillation.
And it's just to hammer it home again. Ectopic, extrasystolic, premature.
All mean the same thing. An early extra beat. Yes, keep that straight.
This systematic approach is invaluable for medical students, especially when facing a complex ECG. Let's talk about the clinical roadmap for ECG analysis of arrhythmias. You mentioned some simple yet powerful rules to follow.
Yes, this is where many students get tripped up by getting overwhelmed, but there's a straightforward system that will serve you well in exams and in the clinic. Rule number 1. This is critical. Do not be immediately distracted by large abnormal waves on the ECG.
Resist the urge.
Exactly. Your eyes will naturally be drawn to them, especially a wide, bizarre QRS complex, but resist that urge initially. Focus on the fundamental smaller components first.
So we start small then with the P waves. That sounds counterintuitive when you see a wildly abnormal QRS.
It is counterintuitive, but it's the key to consistent diagnosis.
Yeah.
Rule number 2, always analyze the P wave first. The P wave, as we discussed, indicates atrial depolarization. So any abnormality in the atria, whether it's a bradycardia from SA node dysfunction, ectopic beats originating in the atria, or tachyarrhythmias like flutter or fibrillation originating from the atria, will manifest as an abnormal P wave. Your action should always be to look at the P wave first and determine, is it there? Is it normal in shape? Is it fast, slow, irregular, or even missing? The implication here is critical. If you find abnormal P waves, it's highly likely that any subsequent QRS complex abnormalities you see are a consequence of that underlying atrial problem.
So the atrial problem is driving the bus.
Often, yes. And remember, abnormal P waves are always small waves. Start small.
Okay, P wave first, no matter what. What's next on the systematic checklist?
Rule number 3. After assessing the P wave, you evaluate the PR interval. This interval, remember, reflects AV nodal conduction. So you're looking for prolonged PR intervals, whether they are regular or irregular. A consistent or progressive prolongation immediately indicates AV nodal pathology, which typically points to some form of heart block. It tells you if the AV bridge is intact and functioning properly.
Okay, check the AV bridge with the PR interval. So if the P wave and PR interval are both completely normal, meaning the atria and the AV node are functioning correctly, but we still see an arrhythmia, then where do we look for the source?
That leads to rule number 4. If the P wave and the PR interval are both normal, meaning the atria are depolarizing properly, and the AV node is conducting impulses through correctly, but you then see very large abnormal QRS complexes, the arrhythmia's origin must be ventricular.
Ah, okay.
This can include pathology in the bundle branches themselves or ectopic foci within the ventricles causing premature beats or tachycardias. Your visual cue here is that abnormal big waves in the presence of normal P waves and PR intervals typically indicate ventricular pathology. This systematic approach, P, PR, QRS, will guide you consistently and effectively, streamlining your diagnostic process.
Beyond just the ECG strip, understanding the clinical relevance of arrhythmias and assessing the patient's pulse are equally vital. In fact, you said feeling the pulse is the first step. What kind of symptoms can these conditions produce for our patients?
Right, arrhythmias, whether they manifest as brady or tachyarrhythmias, share many common clinical symptoms, which can sometimes make initial differentiation tricky based on symptoms alone. Firstly, there are low cardiac output symptoms. This can manifest as syncope or fainting due to insufficient blood flow to the brain, a concept you've thoroughly covered in your cardiovascular block.
Yeah, syncope.
If cardiac output drops sufficiently low, it can quickly lead to shock, given that mean arterial pressure is a direct product of systemic vascular resistance and cardiac output. Furthermore, chronically reduced cardiac output can cause increased filling volumes and pressures in the heart, leading to symptoms of heart failure, which you've explored in depth during your heart failure week.
Okay, low output symptoms. And then there are those direct cardiac symptoms that patients often describe, the ones that really make them seek help.
Yes, exactly. Patients often experience palpitations, which is just an abnormal sensation of their own heartbeat or pulse. They might describe this in various ways: ectopic beats, missed beats, skipped beats, extra beats, or early beats.
Oh, this description.
Yeah. Another common symptom is exercise intolerance, which occurs when the heart cannot adequately increase its cardiac output during physical activity to meet the body's metabolic demands. It's important to emphasize that clinical presentation alone often does not definitively differentiate between brady and tachyarrhythmias, as many of these symptoms overlap. You need the pulse and the ECG to really know.
That's a key point, that overlap.
Yeah.
Why would tachyarrhythmias with their fast rate cause similar symptoms to bradyarrhythmias, which are slow? It seems counterintuitive.
It might seem that way, but the common denominator is ineffective cardiac output. If the heart rate in a tachyarrhythmia exceeds a certain point, for instance, maybe over 180 BPM in a healthy heart, or even above 120, 130 BPM in an unhealthy compromised heart, there's simply less time for complete ventricular filling during diastole.
Not enough filling time.
Exactly. This reduced filling time significantly decreases stroke volume, as per the Frank-Starling mechanism, and consequently, it dramatically reduces cardiac output. This reduction in cardiac output then directly leads to the symptoms like syncope, shock, and heart failure.
Okay, that makes sense.
Additionally, a fast heart rate substantially increases myocardial oxygen demand. This elevated demand can, in itself, precipitate or worsen heart failure, especially in patients with underlying ischemic heart disease. Even if the cardiac output isn't critically low from reduced filling time alone, it's kind of a double whammy.
Right, straining the heart muscle too. So before even touching that ECG, you're saying the first clinical tool is literally the patient's pulse. What precisely are we feeling for when we're at the bedside?
Your initial pulse assessment is invaluable and can quickly narrow down your differential diagnoses. For bradyarrhythmias, you'll detect a slow pulse. The slow pulse can be regular, irregularly irregular, or even regularly irregular, depending on the specific underlying pathology, like Mobitz versus third-degree block.
Okay.
For tachyarrhythmias, the pulse is usually fast, but not always. For example, in atrial fibrillation or a flutter with significant AV nodal block, the ventricular rate might actually be normal or even slow, despite the underlying atrial tachyarrhythmia raging away.
Ah, interesting point.
So the key assessment points are, what is the rate? Is it fast or slow? What is the rhythm? Is it regular? If irregular, is it regularly irregular, like maybe Bugemini or Mobitz and Boas, or irregularly irregular, like AFib? This systematic approach guides your ECG interpretation, allowing you to narrow down the possibilities before you even lay eyes on the tracing.
We've established the normal rhythm and how to broadly classify arrhythmias. Now, let's truly delve into those slow rhythms, starting with when the very impulse generation falters. Let's talk about bradyarrhythmias and disorders of impulse formation, specifically pathology in the sinoatrial node. What's the typical clinical picture you'd see?
In cases of sinoatrial nodal pathology, the clinical picture can range quite a bit, from urgent, severe presentations requiring immediate intervention to more benign, chronic ones. Major clinical syndromes that demand urgent management if the patient is hemodynamically unstable include syncope or fainting, overt shock, and symptoms of heart failure.
The big ones.
Yeah, the big scary ones. However, patients might also present in a more subtle, benign way, simply complaining of palpitations, perhaps due to the very high strike volume, trying to compensate for the low rate or chronic exercise intolerance if their heart is unable to sufficiently increase its rate during physical activity to meet demand.
Okay. And the pulse?
When you feel the pulse in these patients, it will invariably be very slow, and it can be either regular or irregular, depending on the specific SA node dysfunction, like sinus arrest versus sick sinus syndrome, with varying escape rhythms.
And what's the management strategy for these SA nodal issues, particularly in urgent situations where a patient is unstable?
Right. If the patient is hemodynamically unstable, urgent management is absolutely critical. This typically involves the immediate use of muscarinic receptor blockers like atropine.
Atropine.
Atropine works by blocking the parasympathetic vagal stimulation at the heart, thereby allowing underlying sympathetic activation to potentially increase the rate of any escape rhythm that might be present, providing temporary relief.
And long term.
For chronic cases, or if no reversible cause can be found and the bradycardia is symptomatic, artificial pacemaker insertion is often required. This could be a temporary pacemaker for acute issues, or more commonly, a permanent one for long-standing SA nodal pathology that is causing significant symptoms.
Let's turn to the ECG changes for conditions like sinus arrest and sick sinus syndrome. What are we looking for in the strip that screams SA node problem?
For sinus arrest and sick sinus syndrome, when you compare the ECG to a normal tracing, you'll first note the defining feature, a very slow heart rate, characteristic of a bradyarrhythmia. Crucially, while the QRS complexes and T waves generally appear normal in morphology, the hallmark is the absence of P waves, or maybe inconsistently occurring P waves.
No P waves. That's the key.
That's the key. It signifies that atrial depolarization is simply not occurring, or not being consistently initiated by the SA node. Your immediate question should be, if there are no P waves, how are QRS complexes and T waves being generated?
Right, where's the beat coming from?
This is where the concept of an escape rhythm comes in. If the SA node fails, a pacemaker further downstream, most commonly the AV node, takes over, producing these escape beats. If the rate is extremely slow, like less than 40, It might suggest the pacemaker is even further down, perhaps in the bundle of His or the bundle branches, which have those slower intrinsic rates we talked about.
Okay.
It's important to remember that P waves may not be completely absent. Sometimes only some P waves are missing, with an escape rhythm kicking in for alternate beats maybe. In a classic sinus arrest, you might see normal complexes, followed by a sudden, complete absence of complexes. No P wave, no QRS, no T wave indicating failure of the SA node, and no functional escape beat during that pause. This implies insufficient time for spontaneous depolarization in the backup pacemakers to kick in.
Wow, just a flat line for a bit. Scary. And how about pathological sinus bradycardia? It also involves a slow heart rate, but the ECG looks a bit different. How do we distinguish it from, say, an athlete's physiological bradycardia?
Good question. In pathological sinus bradycardia, the key feature is an extremely slow heart rate, often below 60 BPM. But unlike sinus arrest, P waves are present with every QRS complex, and the P waves themselves are occurring at that very slow rate.
Okay, P waves are there, just slow.
Exactly. You might be tempted to dismiss this as physiological bradycardia like you'd see in a very fit athlete with high vagal tone whose heart is just incredibly efficient. However, the critical distinguishing factor here is that in pathological sinus bradycardia, the PR interval is often normal, despite the very slow heart rate.
Why is that significant?
This is significant because normally, as heart rate slows due to increased vagal tone, like in an athlete, AV nodal conduction also tends to slow proportionally, and the PR interval would actually lengthen slightly. A normal PR interval with very slow P waves suggests a primary SA nodal pathology, where AV conduction isn't being affected by the rate itself, indicating a problem with impulse formation rather than impaired conduction through the AV node. It's a subtle but important diagnostic clue pointing towards intrinsic SA node disease.
Got it. Now, let's shift to disorders of impulse conduction, specifically heart block or atrioventricular nodal block. This is where the AV node itself is the bottleneck or the problem.
That's right. These problems fundamentally arise from pathology within the AV node, impairing its ability to conduct electrical impulses effectively from the atria down to the ventricles. Our analysis here relies almost entirely on systematically assessing the PR interval. That little segment of the ECG becomes your guiding star for AV block.
So starting with the simplest first-degree heart block, what's happening here and what does it look like on the ECG?
First-degree heart block is, at its core, a simple, consistent delay in conduction through the AV node. All impulses from the atria do eventually conduct to the ventricles, but they do so slowly. On the ECG, the defining feature is a PR interval that is consistently prolonged. It's longer than the normal upper limit, which is typically 0.20 seconds or 5 small squares on standard ECG paper, and it's prolonged relative to what you'd expect for that heart rate.
Consistently long PR.
Consistently long, same duration for every beat. You'll need to familiarize yourself with these standard ECG measurements. Sometimes the PR interval can be so long that the T wave of the preceding beat appears almost on top of or merged with the P wave of the subsequent beat, which can be visually confusing. Importantly, the P wave rate itself is normal. It's just the conduction through the AV node that's delayed, like traffic slowing down consistently at one specific intersection.
So it's just a delay, not a dropped beat. What's the clinical significance of this for the patient and how do we manage it?
Clinically, first-degree heart block is usually asymptomatic and is often an incidental finding discovered during a routine ECG. It's rarely the cause of a patient's symptoms. When you assess the pulse, it might be slightly slower than normal, but it will be entirely regular.
Okay, usually no big deal clinically.
Generally not on its own. Management primarily focuses on identifying and treating the underlying cause, such as the withdrawal of AV nodal blocking drugs like certain cardiovascular calcium channel blockers, verapamil, diltiazem, or beta blockers, which can slow conduction. At this stage, no artificial pacing is required, but it's important to monitor as it can, in some cases, progress to higher, more symptomatic degrees of heart block, particularly if the QRS is also wide.
Okay, let's move to second-degree heart block, which sounds a bit more serious. This is when some impulses from the atria don't even make it through the AV node to the ventricles.
Indeed. In second-degree heart block, some SA nodal impulses successfully penetrate the AV node and reach the ventricles, but others fail to conduct completely. There are two distinct types you absolutely need to recognize on the ECG, Mobitz type 1 and Mobitz type 2. They have very different implications and underlying pathology.
Let's start with Mobitz type I, also known as Wenckebach phenomenon. What does that characteristic pattern look like on the ECG? Everyone remembers the name.
Wenckebach. Yeah, for Mobitz type I, or the Venka phenomenon, the ECG feature is very characteristic and almost predictable in its pattern. The PR interval gradually lengthens with each successive beat.
Getting longer. Longer.
Until one P wave is not followed by a QRS complex. This is what we call a dropped beat. After this dropped beat, the cycle then resets itself, with the PR interval starting short again and progressively lengthening. This gradual elongation, like a spring slowly stretching before it snaps, is the hallmark of Venka.
Okay, progressive lengthening, then a drop. And clinically?
Clinically, patients might experience palpitations or exercise intolerance. While it can lead to more severe symptoms like syncope, shock, or heart failure, this is less common than with Mobitz type 2, as the block is usually located higher up in the AV node itself. When you feel the pulse, it will be slow and significantly irregular due to those regularly dropped beats. It's often described as regularly irregular.
Okay. And management?
Management involves treating the underlying cause, like ischemia or drugs. If the patient is hemodynamically unstable, atropine might be used to increase the pacemaker rate in the bundle of His as a temporary measure. Artificial pacing might be required in some symptomatic cases, but less frequently than in Mobitz type 2.
And then there's Mobitz type 2. How is that distinctly different from type I, and why is it often more concerning?
Mobitz type 2 is distinctly different and often much more concerning because it usually indicates a more serious conduction abnormality located below the AV node in the His-Purkinje system. On the ECG, you'll see P waves that are present and regular, but some of these P waves are intermittently not followed by a QRS complex, meaning there's an abrupt, complete blockade of conduction for that beat.
Abrupt block, no warning.
Exactly. Crucially, there is no gradual lengthening of the PR interval before the dropped beat. The PR interval for the conducted beats remains constant, though it might be normal or prolonged. You might see this as a consistent pattern, like every second or third P wave is blocked, 2.1 or 3.1 block.
Okay, and clinically this sounds worse.
Clinically, this type can be very severe, commonly leading to profound syncope, shock, or heart failure, because the pauses can be long and unpredictable. Palpitations or exercise intolerance alone are less common as the sole presentation. The pulse is usually slow and can be regular, if it's a consistent 2.1 block, for example, or irregular if the block is intermittent.
Management. Pacemaker territory.
Management again involves treating the cause. However, patients with Mobitz type 2, who are hemodynamically unstable, often require muscarinic receptor blockers like atropine to increase the pacemaker rate as a bridge, though it may not be effective if the block is below the AV node. More importantly, artificial pacemaker insertion, either temporary for acute issues or, much more often, permanent, is frequently required due to the significant and unpredictable risk of progression to complete heart block. This one is taken very seriously and usually warrants pacing.
That progression sounds like a truly serious concern, which leads us to third-degree heart block or complete AV block. This sounds like a total electrical disconnect between the atria and the ventricles.
It is indeed a total electrical disconnect, a complete failure of the AV node, or below, to conduct any impulses from the atria to the ventricles. In third-degree heart block, there's a complete block of conduction. This means the atrial activity, P waves, and ventricular activity, QRS complexes, are completely dissociated.
Completely separate lives.
Totally. The P waves occur at their own normal, regular rate, driven by the SA node, completely independently of the QRS complexes, which represent the ventricular activity. The ventricles only depolarize through a slower escape rhythm originating from a lower pacemaker, such as the bundle of His, or tissues further down in the ventricles.
And on the ECG, how do we spot this dissociation?
On the ECG, you'll see consistent P waves occurring at a regular, often normal rate, but the QRS complexes are completely unrelated to these P waves. They march out at their own slower, regular rhythm. The key is that the relationship between P waves and QRS complexes is totally random. Sometimes a P wave falls before, during, or after a QRS, with no fixed PR interval.
And sometimes those P waves can be hard to spot in third-degree heart block, can't they? You really have to hunt for them.
They can be incredibly challenging, especially if the ventricular rate isn't super slow.
Yeah.
It's often difficult to identify all the P waves, which might be buried within the QRS or T waves, so you must diligently look at every single lead on the ECG, maybe use calipers, to ensure you don't miss them and accurately assess their independent rate and the complete dissociation.
And what if the escape rhythm is coming from really deep in the ventricles?
Right. If the escape rhythm originates from deep within the ventricles, beyond the bundle of His, it's called an idioventricular rhythm. In these cases, the QRS complexes will be extremely slow, like 20-40 BPM, very broad, and often have an abnormal axis, and the T waves might appear abnormal or inverted. This appearance indicates very slow, inefficient conduction through non-Purkinje ventricular tissue. It's literally the heart's last resort and hemodynamically very unstable.
And the clinical presentation for complete heart block. This sounds like a patient who is very, very unwell.
Generally, yes. The clinical presentation is very severe, carrying a much worse prognosis if untreated. Patients commonly present with profound symptoms like recurrent syncope, Stokes-Adams attacks, overt shock, or severe heart failure. It's rare for them to complain solely of palpitations or exercise intolerance. They are often critically ill.
And the pulse. You said the escape rhythm is usually regular?
Correct. When assessing the pulse, you'll find a slow heart rate, but distinctively, the escape rhythm itself is usually regular, not irregular, due to its consistent intrinsic rate, whether it's from the AV junction or ventricles. Management involves identifying and treating the underlying cause of AV nodal blockade, if possible, like ischemia, drugs, Lyme disease. However, due to the high likelihood of hemodynamic instability, urgent action is needed to increase the ventricular rate, usually with temporary pacing. Artificial pacemakers are always required in symptomatic or persistent third-degree heart block, and typically these are permanent pacemakers given the chronic nature of the complete block and the inherent instability. This is a life-saving intervention.
Okay, now let's talk about bundle branch blocks. You mentioned earlier that while they're considered conduction defects, they typically don't cause a reduced heart rate. So what are we seeing on the ECG here, and why are they important to recognize?
That's a crucial point to reiterate. Bundle branch blocks primarily affect the shape and duration of the QRS complex, not necessarily the overall rate of the heart. Remember, the QRS complex represents conduction through the bundle branches and subsequent ventricular depolarization. So, slowed or blocked conduction through these branches results in a very wide QRS complex with an abnormal axis or morphology.
Wide QRS, how wide?
Usually defined as greater than 0.12 seconds, or 3 small squares on the ECG paper. The absolute key differentiator here is that this widened QRS complex occurs with an absolutely normal P wave and a normal PR interval. This tells you the impulse is originating normally in the SA node and getting through the AV node just fine, but then hits a roadblock or detour in the ventricular conduction system. Crucially, every single QRS complex on the ECG will look the same and be abnormally wide, indicating a consistent conduction delay.
Let's break down the two main types. Left bundle branch block, LBBB. What does that distinctive pattern look like on the ECG? What's happening physiologically?
In left bundle branch block, there's a loss of conduction through the left bundle branch system. Physiologically, early depolarization then occurs via the right ventricle, starting from the right bundle branch, and the left ventricle depolarizes abnormally and slowly, primarily through slower cell-to-cell conduction, taking a longer circuitous route.
Okay, slow path through the left ventricle. And the ECG.
On ECG, you'll always see that widened QRS complex, typically greater than 0.12 seconds. The electrical axis is typically toward leads facing the left ventricle, such as V5 and V6, where you'll see a broad, often notched or slurred R wave. It might look like an M shape sometimes. Conversely, it's away from leads facing the right ventricle, like V1 and V2, where you'll often see a deep, wide S wave, maybe looking like a WA. You might also see a left-shifted vertical plane electrical axis moving towards lead AVL. It's a very distinctive pattern once you learn to spot it: wide QRS, characteristic changes in V1 and V6.
Okay, and how about right bundle branch block, RBB? What are its ECG hallmarks?
For right bundle branch block, the right bundle branch is blocked. Early ventricular depolarization occurs via the left bundle branch first, and then the right ventricle depolarizes slowly, again primarily through cell-to-cell conduction. On the ECG, you'll always have a widened QRS complex, again greater than 0.12 seconds. A truly characteristic pattern, the one everyone learns, is the RSR pattern, often described as rotted ears, particularly noticeable in the right precordial leads, V1 and V2.
RSR and V1, V2, rabbit ears. Got it.
You see an initial R wave, a deep S wave, then a second taller R wave, the R prime. In the left-sided leads like V5, V6, and lidi, you'll often see a wide, slurred S wave, reflecting that late right ventricular depolarization moving away from those leads. In essence, with RBBB, you have a widened QRS with that classic RSR and V1, V2, and wide S waves laterally.
What's the clinical picture for bundle branch blocks, and crucially, what's their management? When do we worry about them, since they don't usually cause bradycardia?
Right. Bundle branch blocks themselves are usually an incidental finding discovered in patients with underlying cardiac risk factors, like uncontrolled hypertension, diabetes, or coronary artery disease. They often don't cause specific symptoms directly related to the block itself. Critically, when you assess the pulse, there is generally no bradycardia and no irregular pulse directly caused by the bundle branch block itself. However, there are two crucial clinical circumstances where recognizing a bundle branch block is paramount for you as medical students and future clinicians. You have to know these.
Okay, lay them on us. What are the critical circumstances?
First, a patient presenting with acute chest pain and a new, or presumed new, left bundle branch block, LBBB, should immediately raise suspicion for an acute coronary syndrome, specifically a potential ST elevation MI equivalent.
New LBBB plus chest pain equals emergency.
Absolutely. This is a medical emergency. Standard ST segment changes, which are usually your key for diagnosing ischemia or infarction, are incredibly difficult to assess accurately in LDBB because the presence of the block itself profoundly alters ventricular repolarization and the ECG, often masking or mimicking ST elevation or depression. This necessitates prompt biomarker testing, cardiac enzymes, and admission for urgent cardiac monitoring and workup, potentially even straight to the cath lab based on clinical suspicion, because the LBBB fundamentally alters the ECG's interpretation for ischemia. You can't rely on your usual ST segment rules. Specific criteria like Sgarbossa criteria exist but are complex. Treat it as an MI until proven otherwise.
Okay, LBBB with chest pain always demands an emergency workup. What's the second important clinical circumstance?
The second is patients who present with heart failure in LBBB. In these cases, systolic function can be significantly reduced not just by the underlying heart failure pathology, but also because the LBBB causes asynchronous ventricular contraction. The left ventricle collapses slightly before, or more accurately, the activation is disordered and prolonged compared to the right. Normal synchronized ventricular contraction actually enhances systole, so this lack of synchrony, this dyssynchrony, impairs the heart's overall pumping efficiency.
So the LBBB makes the heart failure worse.
It can significantly contribute, yes. If their heart failure doesn't improve sufficiently with standard medical care, like ACE inhibitors, beta blockers, diuretics, one vital intervention that can make a huge difference is cardiac resynchronization therapy, CRT, which involves biventricular pacing.
CRT, biventricular pacing. Tell me more.
This therapy uses a special pacemaker with leads in the right atrium, right ventricle, and also the left ventricle, usually via the coronary sinus vein. It aims to resynchronize ventricular contraction, literally ensuring both ventricles contract simultaneously and more effectively. This can significantly improve systolic function, reduce heart failure symptoms, improve quality of life, and even reduce mortality in appropriately selected patients. It's a really important therapy for heart failure patients with LBBB and reduced ejection fraction.
We've thoroughly covered the slow rhythms and the persistent conduction blocks. Now let's transition to the unexpected interruptions, extrasystolic beats. These are those early, often unsettling beats, often originating from non-nodal or non-conducting tissue, and they can sometimes lead to broader rhythm changes. To understand them properly, we need to quickly revisit a critical concept, the refractory period of cardiac cells.
That's absolutely right. The refractory period is fundamental to understanding why these early beats look the way they do on an ECG and why sometimes they conduct and sometimes they don't. Unlike neuronal action potentials, cardiac action potentials have that distinct, prolonged plateau phase where calcium influx occurs.
All right, the plateau phase.
This plateau phase corresponds roughly to the absolute refractory period on the ECG, aligning somewhat with the QRS complex in the ST segment. During this period, no new impulse, regardless of its strength, can generate another action potential. The cardiac myocytes are completely unresponsive, like a reset button that's held down. Cannot fire again, period.
So it's like a hard reset, nothing can get through. What about the relative refractory period?
The relative refractory period occurs during the repolarizing phase of the action potential, corresponding roughly to the T wave, especially the downslope. This is a critical window. An impulse generated and arriving at the cardiac myocytes during this point can depolarize them, but because the cell isn't fully reset yet, some sodium channels might still be inactivated, potassium channels are open, the resulting action potential will be abnormal. It will be slower to rise, shorter in duration, and often follow an abnormal conduction pathway.
Okay, can fire, but it'll be weird.
Exactly. It's like trying to fire a gun before it's fully reloaded. Understanding these two periods, absolute and relative, is absolutely key to explaining the varied and sometimes bizarre ECG appearances of premature beats.
Let's apply this to atrial premature contractions, or APCs, also called PACs sometimes. What do they look like on the ECG, and how do those refractory periods influence their appearance?
Right, APCs or PACs are characterized by an abnormal small wave, an abnormal P wave, that occurs prematurely, earlier than the next expected sinus P wave. This early P wave usually looks different from the normal sinus P waves because it originates from a different spot in the atria.
Okay, early, different-looking P wave.
The key is that the QRS complex following it can be normal, absent, or abnormal wide, depending entirely on when that early atrial impulse arrives at the AV node relative to the refractory period of the preceding normal beat.
Aha, depends on the timing relative to the T wave.
Exactly. So our crucial ECG analysis approach for APCs is this. Always analyze the small complexes, the P waves, first. Look specifically for abnormal P waves that are different in shape or occur early. Do not allow your eyes to be drawn to the large QRS complexes initially, even if they look strange. The implication here is that if an abnormal P wave is present, the arrhythmia is definitively supraventricular in origin. It comes from above the ventricles.
Okay, find the early P first. So how does that early P wave interact with the refractory periods to produce these different outcomes on the ECG?
There are three main types of APC conduction you'll encounter. First, an APC with physiological AV nodal block. This happens when the early atrial impulse arrives at the AV node during the absolute refractory period, think QRSST segment, of the previous normal beat.
Too early, hits a brick wall.
Exactly. On the ECG, you'll see the abnormal P wave occur, but it is not followed by a QRS complex. This appears as a missing beat, or a pause, because the AV node simply cannot conduct the impulse. Interestingly, the next normal SA nodal P wave might also appear missing or delayed, because the atria themselves might still be somewhat refractory from that early atrial depolarization, resetting the SA node timing.
Oh, okay, that makes perfect sense. The AV node is just totally unresponsive. What's the second type of APC conduction?
Second, we have an APC with aberrant ventricular conduction. This occurs when the early atrial impulse arrives at the AV node during the relative refractory period, think around the T wave of the previous beat.
Hits the AV node when it's only partially recovered.
Right. Here, the abnormal P wave is followed by an abnormal QRS complex. The QRS is typically wide, indicating slow conduction through the ventricles, and often has an abnormal morphology, frequently resembling a right bundle branch block pattern, because the right bundle branch tends to repolarize slightly later than the left. This is because conduction through the AV node in ventricles is partial and abnormal, as the ventricular tissue, especially part of the conduction system, is not yet fully repolarized and ready for a normal, rapid pathway. It's like trying to run through a door that's only halfway open and maybe one side opens slower than the other.
Okay, wide QRS after the early P. And the third type is the best case scenario for an APC where it doesn't cause too much disturbance, right?
Yes, relatively speaking. The third is an APC with normal ventricular conduction. In this case, the early atrial impulse arrives at the AZ node after both the absolute and relative refractory periods, meaning after the T wave is fully completed of the previous beat.
Arrives when the coast is clear.
Exactly. On the ECG, you'll see an abnormal P wave that occurs early, and it is followed by a normal-looking narrow QRS complex and T wave. This happens because the impulse can penetrate the AV node in ventricles normally, as they have fully repolarized and are ready for normal conduction. It's an early beat, but perfectly conducted down the usual pathways.
What's the clinical presentation of APCs? What do we feel on the pulse? And importantly, how are they typically managed?
The most common symptom for patients with APCs is simply palpitations. They feel skipped, missed, or extra beats. It can be quite unsettling for them. On the pulse, you might detect an irregularly irregular or regularly irregular rhythm, like atrial bigeminy, where every other beat is an APC, depending on how often they occur.
Management. Are they usually benign?
Often they are, especially if infrequent. However, it's crucial to always investigate for underlying cardiac conditions that might be making the atria irritable, like hypertension, heart failure, valvular disease, electrolyte imbalances, or even just caffeine or stress. Frequent APCs, for example, can be highly suggestive of underlying pathology. The primary approach is to treat the underlying cause if found. Critically, frequent APCs can sometimes trigger more serious, sustained tachyarrhythmias like atrial fibrillation or flutter by creating reentry circuits, so they shouldn't be dismissed entirely, especially if very frequent or symptomatic. Therefore, further investigation by a cardiologist, often using Holter monitoring or even implantable loop recorders, might be needed to assess the patient's long-term risk and guide potential therapies if needed.
So those are atrial premature contractions originating above the ventricles. Now let's move to ventricular premature contractions, or VPCs, or PVCs. How do we identify these on an ECG, and what are their characteristic features?
Right, with VPCs, the general rule, the key identifier, is that there is no abnormal P wave preceding the premature ventricular complex. You might see a normal sinus P wave buried somewhere near it or in it, but there's no early P wave triggering it. This is your immediate red flag that the abnormality originates directly in the ventricles themselves.
No early P wave, origin is ventricular. Got it.
We generally see two main types of VPCs based on their ECG morphology, which can sometimes give clues about their origin within the ventricle.
What's the first type of VPC?
The first type is an early but relatively normal-looking QRS. Well, maybe not normal, but narrower than the classic VPC. Here, the QRS complex occurs much earlier than normal, but critically there is no preceding early P wave. The QRS complex itself might be slightly wide, but still relatively narrow compared to the really bizarre ones. This usually indicates that the VPC originated from high up in the ventricular conduction system, like the proximal portion of the bundle of His, or high up in the Purkinje system.
Okay, so using the fast lanes still.
Somewhat, yes. This allows for relatively rapid ventricular conduction because it still utilizes the fast Purkinje system for most of the ventricle. A consequence of this is that the subsequent normal SA nodal P wave, which would normally occur, is often not conducted because the AV node and ventricles are in their absolute refractory period from the early VPC. This creates a period on the ECG that appears like a missed beat or a pause before the next normal beat.
And the second type, which is probably what most people picture when they think of a VPC, the one that really looks abnormal and wide.
That's the early and markedly abnormal QRS complex, which is indeed the most common appearance for VPCs. On the ECG, you'll see a very large, bizarre, abnormal QRS complex that occurs prematurely. It's typically very wide, indicating slow conduction, and its axis is often wildly in the wrong direction, looking completely different from the normal QRS complexes. Again, there is no preceding early P wave.
Where do these ones come from?
This type of VPC originates from non-conducting myocardial tissue within the ventricles, not from the bundle branches or Purkinje fibers directly. The abnormality in appearance, the wide, complex, and abnormal axis, is due to this slow cell-to-cell conduction, as it's not following the normal, rapid Purkinje highway, and the abnormal direction of depolarization due to its ectopic origin far from the normal pathways.
And a really characteristic feature of these wide, bizarre VPCs, which helps confirm the diagnosis, is something called a compensatory pause, isn't it?
Yes, the compensatory pause is a very helpful hallmark that helps distinguish VPCs from some other premature beats, like interpolated VPCs or some APCs. This early VPC often causes that missed beat appearance, followed by a longer than normal pause before the next normal beat occurs.
Yeah.
This pause happens because the normal SA nodal impulse, the P wave that would have occurred on time, falls during the VPC's absolute refractory period and therefore is not conducted to the ventricles. This allows the SA node to continue firing at its regular rhythm, undisturbed. So the interval between the beat before the VPC and the beat after the VPC is exactly equal to 2 normal beat cycles. The rhythm after the pause resumes exactly on time with the original sinus rhythm. That's the full compensatory pause.
Let's talk about the clinical presentation, what we'll feel in the pulse, and the crucial management steps for VPCs.
For VPCs, the symptoms are primarily palpitations, with patients feeling skipped, missed, thuds, or fluttering beats. Usually there are no other major cardiac presentations initially, differentiating them somewhat from more severe arrhythmias, unless they are extremely frequent, occur in runs, non-sustained VT, or fall in a vulnerable period, R-on-T phenomenon, which can trigger VF.
And the pulse.
When you assess the pulse, it can be regularly irregular, like ventricular bigeminy or trigeminy, or irregularly irregular if they occur randomly.
Yeah.
You'll distinctly feel those skip beats or missed beats where the VPC occurred but might not have generated a palpable pulse, followed by that compensatory pause.
Management. How seriously do we take these?
Management is crucial. You must investigate for underlying causes, especially if the VPCs are frequent. For example, if every third beat is a VPC, trigeminy, or every second bigeminy, or if they occur in pairs or runs. This high frequency or complexity strongly suggests underlying ventricular pathology.
What kind of underlying pathology should we be meticulously looking for with frequent VPCs? What are the red flags?
You should meticulously work to exclude serious underlying conditions such as coronary artery disease, especially ischemia, cardiomyopathy leading to heart failure and ventricular scarring, valvular heart disease, active myocarditis, electrolyte abnormalities, especially low potassium or magnesium, or drug toxicity, like digoxin. The presence of frequent or complex VPCs carries a significant risk. They can be a precursor to sustained ventricular tachyarrhythmias, VT or VF, which are much more dangerous and potentially lethal.
Okay, so frequent VPCs need a workup. How do cardiologists assess the risk?
Cardiologists use various investigation tools, including extended Holter monitoring, for 48 hours or even longer, exercise stress testing to see if VPCs increase or decrease with exertion, echocardiograms to look for structural heart disease, and sometimes cardiac MRI. For very infrequent but suspicious symptoms, subcutaneous implantable loop recorders that can continuously monitor for up to 3 years might be used to capture events and thoroughly assess this risk.
And if the risk is high?
If patients are deemed at high risk of lethal ventricular events based on frequency, complexity, underlying heart disease, reduced ejection fraction, etc., implantable cardioverter defibrillators, ICDs, may be implanted. These devices monitor the heart rhythm continuously and can deliver a shock to terminate VT or VF, significantly reducing the chance of sudden cardiac death. Additionally, if the VBCs are very frequent, symptomatic, and originate from a discrete, identifiable ectopic focus within the ventricles, catheter ablation is also a viable option to target and eliminate the source of the arrhythmia, reducing the burden and potentially the risk. Beta blockers are often first-line medical therapy.
We've systematically broken down the slow rhythms and the intermittent extra beats. Now, for the grand finale, let's tackle tachyarrhythmias when the heart races. These are often the most urgent and potentially dangerous. What are the absolute general principles for analyzing these fast rhythms on an ECG?
Right. The golden rule for tachyarrhythmia analysis is the same as for ectopics, and it bears repeating because it's so important. Always, always look for small abnormal waves, P waves first, before allowing your eyes to be drawn to the large, often bizarre QRS complexes.
P waves first, even in tachycardia.
Especially in tachycardia. This disciplined approach will save you from misdiagnosis, like mistaking SVT with aberrancy for VT, and guide you to the correct anatomical origin. For identifying the origin, it's pretty straightforward. If identifiable abnormal P wave are present, even if they look weird like flutter waves, the source is definitively atrial or supraventricular. If there is no discernible P wave related to the QRS, or if there's AV dissociation, then the source is almost certainly ventricular.
That's a crystal clear differentiator. And you mentioned a quick bedside tool for differentiating atrial from ventricular tachyarrhythmias based on the QRS complex width. This sounds like a critical point for rapid assessment, especially in an emergency.
Yes, this is a vital clinical discriminator that can guide immediate management, although it's not foolproof.
Yeah.
If you observe a narrow QRS complex tachycardia, meaning the QRS is less than 0.12 seconds wide, it is usually supraventricular SVT in origin.
Yeah.
This is because conduction is occurring rapidly through the AV node and down the normal ventricular conduction system, his Purkinje, resulting in a narrow QRS, even if the atria or AV node are firing rapidly. Examples include AVNRT, AVRT, atrial tachycardia, atrial flutter with rapid conduction.
Narrow QRS usually means SVT.
Okay.
And why?
If you see a broad QRS complex tachycardia, QRS wider than 0.12 seconds, it is statistically much more likely to be ventricular in origin. VT. This is because conduction within the ventricles is slow and abnormal, originating from the ventricle itself and not following the rapid Purkinje fibers. However, remember that SVT can present with a wide QRS if there's underlying bundle branch block or rate-related aberrant conduction, SVT with aberrancy.
The exception, SVT with aberrancy.
Exactly. But the clinical significance of this distinction cannot be overstated. Ventricular tachyarrhythmias are often lethal and demand immediate aggressive intervention. So while SVT with aberrancy exists, the safest default assumption for a wide complex tachycardia, especially in a patient with known structural heart disease, is that it's VT until proven otherwise. Treat it seriously. Narrow complex tachycardias, while urgent, generally do not require immediate defibrillation as a first-line therapy unless the patient is profoundly unstable. This width difference is your quick initial decision-making tool.
So let's talk about the general management approaches for both atrial and ventricular tachyarrhythmias. What are the main tools in our arsenal?
The management strategies vary significantly based on the specific type of arrhythmia, the hemodynamic stability of the patient, and the underlying cause. For atrial tachyarrhythmias like AFib, flutter, AVNRT, if the patient is stable, a primary approach is rate control, achieved by blocking the AV node to slow the ventricular response rate. Drugs commonly used include intravenous beta blockers like metoprolol, esmolol, non-dihydropyridine calcium channel blockers like diltiazem, verapamil, digoxin in some cases, especially heart failure, and sometimes amiodarone if others fail or are contraindicated.
Slowing the ventricular rate. Okay. What about getting back to normal rhythm?
That's rhythm control. This aims to restore normal sinus rhythm, often using antiarrhythmic drugs like flecainide, propafenone, amiodarone, sotalol, depends on structural heart disease presence, or, more commonly and effectively for many SVTs and unstable atrial rhythms, synchronized electrical cardioversion.
Cardioversion, when is that needed?
Cardioversion, delivering a shock synchronized to the R wave, is required urgently if the patient is hemodynamically unstable, e.g. hypotensive, altered mental status, chest pain, acute heart failure, due to the tachycardia, regardless of whether it's narrow or wide complex. If it's an elective cardioversion, example for persistent AFib, it's typically done under sedation in a controlled setting, often after ensuring no atrial clot is present via transesophageal echo or adequate anticoagulation.
And for the really dangerous ones like VFib?
For emergency situations such as ventricular fibrillation or pulseless ventricular tachycardia, immediate unsynchronized defibrillation, a high-energy shock delivered immediately, must be performed wherever a defibrillator is available. In the ward, casualty, anywhere. There's absolutely no time to wait. That's the cornerstone of ACLS. For stable VT, you might try antiarrhythmics like amiodarone first, or proceed to synchronized cardioversion.
What about chronic management, especially for common arrhythmias like atrial fibrillation? It's not just about the acute episode.
Critically important point. For chronic atrial fibrillation or flutter, long-term anticoagulation is paramount for most patients, based on their stroke risk profile, calculated using scores like CHA2DS2 VASI. Due to the chaotic, ineffective contraction of the atria, there's significant blood stasis within the atrial appendages, creating a high risk of thrombus formation. If these clots break off, they can embolize, leading to devastating events like stroke or peripheral arterial occlusion. Anticoagulation with warfarin or newer direct oral anticoagulants like apixaban, rivaroxaban prevents this.
Okay, anticoagulation is key for AFib flutter. Anything else long-term?
For severe or specific cases, particularly symptomatic arrhythmias refractory to drugs, catheter ablation may be considered by electrophysiologists. This involves mapping the heart's electrical activity and using radiofrequency energy or cryotherapy to destroy the abnormal tissue causing the arrhythmia. Brudgy, isolating pulmonary veins for AFib, ablating slow pathways for AV-NRT, or targeting ectopic foci for VT. And as we mentioned, for high-risk patients with recurrent ventricular tachyarrhythmias, or those who've survived cardiac arrest, implantable cardioverter defibrillators, ICDs, are a key, often life-saving intervention to prevent sudden cardiac death.
Let's break down atrial tachyarrhythmia specifically, starting with atrial flutter. What are its characteristic ECG features, and what's the clinical presentation?
In atrial flutter, the ECG will show those multiple regular small waves, P waves, which are actually flutter waves, F waves, often described as a classic sawtooth pattern, particularly evident in inferior leads, pair 3, AVF, and sometimes V1. The key here is their regularity and very rapid atrial rate, often around 250, 350 BPM, typically close to 300.
Regular sawtooth F waves, got it.
Most QRS complexes will be narrow, confirming the supraventricular origin and conduction through the normal ventricular conduction system. However, because the AV node can't possibly conduct at 300 BPM, you'll almost always see some degree of physiological AV nodal block, most commonly at 2.1 block, meaning a ventricular rate around 150 BPM, but it could be 3.1, 4.1, or even variable block, leading to an irregular ventricular rhythm sometimes. You can also see aberrant ventricular conduction if a flutter wave arrives at the AV node during its relative refractory period, resulting in an occasional wide abnormal QRS, mimicking VT if the block is consistent.
Okay. Clinical.
Clinically, patients often present with palpitations, shortness of breath, dizziness, or fatigue, especially if the ventricular rate is rapid, like 150 BPM with 2.1 block. Symptoms of reduced cardiac output can occur. Acute management focuses on controlling the ventricular rate, typically using IV beta blockers or calcium channel blockers, while anticoagulation should be considered similar to AFib. Rhythm control with cardioversion is often successful, and catheter ablation targeting the typical flutter circuit in the right atrium, the tricuspid isthmus, is highly effective for long-term cure.
And now for atrial fibrillation, AF, which is arguably one of the most common arrhythmias students will encounter in their practice. How does it present, and what are its key ECG features?
Indeed, AFib is incredibly common, especially in older populations and those with underlying heart disease. Patients with atrial fibrillation typically present with tachycardia and, most importantly, an irregular rhythm. That's the pulse finding you'll pick up. On the ECG, you'll observe no distinct P waves. Instead, you see multiple irregular low-amplitude fibrillatory waves, F waves, which are chaotic and often just look like a wavy or coarse baseline, especially visible in leads like V1.
No P waves, just fibrillatory waves and irregular QRS.
Exactly. The hallmark is the irregular ventricular response, varying RO intervals. The majority of the QRS complexes will still be narrow, confirming the supraventricular origin. Similar to flutter, you can have aberrant ventricular conduction, where some QRS complexes are broad and abnormal if an atrial impulse happens to arrive very early during the relative refractory period. This is known as Ashman phenomenon if it follows a long short cycle. And you'll always have physiological AV nodal block, where many of the hundreds of chaotic atrial impulses, 400, 600 per minute, are simply not conducted through the AV node because they arrive during its absolute refractory period, leading to that characteristic irregularity of the ventricular response. You might also see variable QRS amplitude, as those fibrillatory waves can sometimes summate with or subtract from the QRS complex.
And the full clinical picture for AF, including the pulse and management, both acute and long-term.
Clinically, patients with AF commonly experience palpitations, that unsettling feeling of their heart racing, fluttering, or just feeling chaotic. However, they can also present with more severe issues like shock, acute heart failure, especially if the rate is very fast, rapid ventricular response, or RVR, angina, or syncope, particularly due to the high ventricular rates reducing filling time and cardiac output. Heart failure can also arise or worsen due to the increased myocardial oxygen demand from the rapid heart rate, especially in those with underlying ischemic heart disease, or due to the loss of the atrial kick contribution to ventricular filling. Remember, AF can be paroxysmal, intermittent, self-terminating, persistent, requires intervention to terminate, or permanent. It might only be detected through extended monitoring if symptoms are infrequent.
And the pulse.
When you feel the pulse, it will be characteristically irregular. There's no predictable pattern to the beats at all. And the rate can vary from slow, if there's underlying AV nodal disease or medication effect, to very rapid RVR.
Management, acute and long-term.
For acute management of new onset or rapid AFib, the first step is to assess hemodynamic stability. If unstable, synchronized cardioversion is needed immediately. If stable, the focus is usually on rate control first, using beta blockers, calcium channel blockers, or digoxin. You also need to identify and manage any underlying pathology or triggers. For example, heart failure, exacerbation, infection, pulmonary embolism, thyroid storm, alcohol withdrawal. Rhythm control, trying to get back to sinus rhythm with drugs or cardioversion, might be considered, especially in younger patients' first episodes, or if symptoms persist despite rate control. But the decision is complex and individualized. Long-term management is absolutely critical. Anticoagulation is essential for most patients based on their CHA2F2 VASC score to prevent stroke. Decisions about long-term rate versus rhythm control strategy are made collaboratively with the patient. Catheter ablation, typically pulmonary vein isolation, may also be considered for symptomatic patients refractory to medication or who prefer a non-pharmacological approach. Lifestyle modifications, managing hypertension, diabetes, sleep apnea, weight, are also crucial.
Finally, let's turn to ventricular tachyarrhythmias, which are often the most urgent and potentially lethal forms of arrhythmia: ventricular flutter and ventricular fibrillation.
These are indeed the most critical ones you'll face. Ventricular tachyarrhythmias are often non-sustained, meaning they might only last for 3 or 4 beats, and are frequently detected incidentally on Holter monitoring in patients with heart disease. However, sustained forms are medical emergencies, usually lethal if not immediately treated. For ECG analysis, the key differentiator, as we said, is that no Q waves are visible that are related to the QRS complexes. You might see dissociated P waves sometimes in VT, but not in VF. The immediate signal that this is ventricular in origin is the overwhelming presence of broad QRS complexes, typically over 0.12 seconds wide, often looking bizarre. This finding should trigger an immediate and high level of alarm for you as a clinician.
So starting with ventricular flutter, V-flutter, how does that typically appear on an ECG and what does it mean for the patient?
On an ECG, ventricular flutter is characterized by no discernible P waves related to the QRS. You'll see very broad QRS complexes, unequivocally indicating a ventricular origin. Critically, these broad complexes maintain a regular rate and rhythm, often extremely fast, ranging typically from 150 to 300 BPM. It often appears as large, regular sinusoidal waves, making it challenging to differentiate between what would normally be QRS, ST segment, and T waves. It's just a continuous undulating waveform that looks like a sine wave.
Regular sine wave pattern. And clinically?
Clinically, patients with V-flutter are almost always acutely unstable and rapidly deteriorating, often pulseless or soon to be pulseless, as their heart is essentially contracting too fast and inefficiently to pump blood effectively. It's often a precursor to VFib. It demands immediate treatment, usually defibrillation.
And then the chaotic, often immediate emergency, ventricular fibrillation. VF, this is the one that demands immediate, decisive action, the ultimate electrical chaos.
Ventricular fibrillation is unmistakable and truly a lethal change requiring immediate action. It is the most common rhythm found in adult cardiac arrest cases initially. On the ECG, there are no P waves. Instead, you'll see very large, extremely irregular, chaotic waves. The complexes are uncoordinated, constantly changing in shape and amplitude. There's no discernible rhythm, no organized electrical activity. It's impossible to differentiate any organized atrial or ventricular events. It's just electrical anarchy.
And clinically?
Clinically, the patient is in cardiac arrest, unresponsive, pulseless, and apneic, not breathing. The heart is merely quivering chaotically, not effectively pumping any blood. This is full cardiac arrest, requiring immediate CPR and defibrillation.
Given how lethal these ventricular tachyarrhythmias are, especially VFib, what's the absolute top priority for management? What do you do first?
The absolute highest priority for managing pulseless ventricular tachyarrhythmias, VT or VF, is immediate, high-quality CPR and defibrillation. This must be done as quickly as possible wherever a defibrillator is available, whether in the ward, the clinic, the street, or the casualty department. This is not something you delay for any reason. Time is myocardial tissue and brain function. If cardiac output is absent, there's no time to wait for anything else. Start CPR, get the pads on, shock as soon as the defibrillator is ready. Follow ACLS protocols rigorously.
CPR and shock. Got it. What about after the immediate emergency?
Beyond immediate resuscitation, long-term management involves identifying and managing any underlying cardiac pathology that predispose the patient to these arrhythmias, such as acute ischemia, requiring cath lab, severe heart failure, electrolyte disturbances, or inherited channelopathies. Antiarrhythmic drugs, such as imidazole or lidocaine, may be used during the resuscitation attempt and sometimes for prevention afterward. For those who survive cardiac arrest due to VTVF or are deemed at high risk for it, an implantable cardioverter defibrillator, ICD, is usually indicated for secondary prevention. This is critical for preventing sudden cardiac death. Lastly, if the VT originates from a discrete ectopic focus or reentrant circuit within the ventricles, catheter ablation might be an option to target and eliminate the source of the arrhythmia, reducing recurrences, ICD shocks.
Wow. We've covered a huge amount of ground there. We've journeyed through the intricate electrical system of the heart, from its normal symphony to the various ways it can falter, whether slowing down in bradyarrhythmias, racing in tachyarrhythmias, or skipping beats with ectopics. You should now have a, hopefully much clearer understanding of the underlying physiology, the specific ECG manifestations, and the critical clinical implications and management strategies for each.
Absolutely. And just remember that systematic approach to ECG analysis, starting with the P wave, assessing the PR interval, then examining the QRS complex that really is your most powerful tool for diagnosis. Combine this with your understanding of the clinical presentation and pulse characteristics we discussed, and you're well on your way to mastering arrhythmias for your upcoming exams and, much more importantly, for the well-being of your future patients. Nail down that systematic approach.
Definitely. And as you delve deeper into patient care, here's something to think about, maybe a final provocative thought. How might the psychological stress and anxiety associated with a patient actually feeling their abnormal heart rhythm, the palpitations, the skipped beats, the racing heart, impact their perception of their illness and their adherence to treatment, even for arrhythmias we might consider relatively benign electrically?
That's a really important point. It's not just about the electrical signals on a piece of paper. It's about the profound lived experience of the patient, the fear and anxiety these sensations can cause. Keep that human element front and center as you prepare to care for your future patients.